welcome to our Women's Wellness Wednesday for this week. We're going to talk about pap smears and the human papillomavirus and cervical cancer. I think a conversation like this starts the best if we start with the HPV virus or the human papillomavirus, because that is actually the root cause of abnormal pap smears and cervical cancers. So statistically, 85% of our population is walking around already exposed to one form or one strain of the HPV virus. They say that if you've had 2 or more sex partners in your lifetime, you've at least been exposed, or you're at least in a carrier state with the virus. So carrier state means you are carrying the virus, you can give it to others, but it's not actively causing cell change in your own body. Those are big statistics, and that's why we actually have a vaccine for the virus. For the longest time, we only gave the vaccine to ages 9 to 27, but they've now expanded that not only to giving it just to girls, but they give it to boys, and we now go up to the age of 45. So everyone who feels like they're interested in that, we can definitely talk to you and get you access to that. We have it here in the office. So HPV has hundreds of strains, and they all have names. The names are numbers, and so they might be type 4, type 6, type 16, type 45. They separate these into 2 groups, basically. There's low-risk types of the virus, and there's high-risk types of the virus. The low-risk types of the virus haven't really been shown to cause cervical cancer, but we do know they can cause something called condyloma acuminata, and the slang term for that, or what everyone uses, is genital warts. But those don't tend to progress into some type of a cancer. We do watch the skin for changes and things like that. The high-risk types of the virus are the ones that we really watch more closely. And it's a whole pod of numbers, the names, but there are a few of these numbers that we tease out specifically and monitor for, and that's type 16, type 18, and type 45. If you have a pap smear and it comes back abnormal and your HPV is positive, they have a clump of numbers that they'll just say you were positive for one of these in this group, or they then will tell us negative for 16, 18, and 45, or maybe positive for one of those. If you are positive for one of those that we're watching more closely, we kind of look at you a little more seriously, but the next step from that is to get a colposcopy. To be clear, pap smears are just screening tests. They are not diagnostic, and so when you get an abnormal pap smear, we consider that to be like the red flag that says, hey, it's time to check this out. Then we have to do something diagnostic, which is a colposcopy, and that is what is sitting next to me. This is a colposcope. It doesn't actually touch you during the exam, but it allows us as providers to look through this, kind of like we're looking at your cervix underneath a microscope, and identify cells that might be abnormal and sample or biopsy them. So I always tell my patients that end up in this room with me with this, I talk about pap smears like a staircase. And at the bottom of the staircase is a normal pap smear, and at the top of the staircase is cervical cancer. And people can go this and that on the first step up, but I always say it goes like this: ascus, low grade; moderate, high grade; CIS, cancer. The thing is, there's a few things. ASCUS stands for atypical squamous cells of undetermined significance, which is a big blurb of words, but it's a gray area. When they looked at your pap smear, they couldn't say it was normal, but they couldn't actually pick an abnormal category for it either. So that automatically gets tested for HPV, and then the HPV, whether it's positive or negative, dictates what we do with that pap smear. Low grade, we always do colposcope. Moderate and high grade are now fused together as one high grade, but it used to be we tease these out a little bit. CIS stands for carcinoma in situ. That means that those cells have progressed to a cancer, but it's contained. And then of course there's the full-blown disease. Colposcopy gives us the diagnosis. This is how we react and either offer you a follow-up pap, or we need to do a procedure on your cervix to help you with your pap smear. But there's all kinds of guidelines swirling around that we monitor, and that's why we do those things. So we now start pap smears at 21. We have new guidelines, and they've changed even since the first time that they changed, and it confuses everyone. Here in our office, Dr. Woods and I and Dr. McCarville kind of agree that the guideline about separating your pap by 3 years is about as far as we're willing to go with our population. 5 just seems too much. But basically, those are just guidelines. They are not rules. We have to talk to you, we have to take your history, we have to understand your risk factors. If you are someone that has higher risk factors, we may pap you every year. The pap smear is dictated when you come in for your well woman visit every year. The pap smear is not your well woman. The well woman is actually an exam we do every year, and we determine your risks and we decide if you need a pap smear that year. I hope we've stimulated some questions. We're happy to answer anything you want, and I hope you guys have a great day.